Hello, hello. Hi, everyone. Happy Wednesday. So excited to see everyone here. We are just going to hop in today because I know that today is going to end up being a discussion where we'll get cut off because this always happens because ERP is just so exciting, I think, for all of us to talk about. And, of course, I'll start with some housekeeping stuff. But before we get in, I just want to remind you guys today we are here to talk about, I'm going to call it ERP 102 because we did that 101 with John Abramowitz a couple of months ago. And we kind of, that talk, which I encourage people to go on and watch, was really focused on like, how do I find a provider? What are the questions I should be asking? How do I know if someone's had some training and background in ERP? And today what we're going to talk more about is like, what should it feel like in practice, right? What is some of the language that we use? What are some of the things you should expect or not expect? How has ERP evolved over the years, right? When all of us started ERP work, it was many years ago, either as individuals or professionals or both. And it's really evolved. And, one of the things I'm always talking about here at our clinic is I want to make sure we are advancing with new techniques, new interventions. And y'all know one of our favorite webinars that we did, I think last year, Chris, was on social justice-based ERP, and it was what the plenary was on at the IOCDF last year. And that was an awesome webinar where we really talked about how, some of the old school ERP stuff we were doing is actually not just bad and we shouldn't necessarily be doing it, but it's also stigmatizing to certain populations and individuals and groups. And we need to think about how we can actually do ERP that is still uplifting. And so I always kind of call it like a softer ERP approach. So anyway, that's going to be today. I'm so excited. As always, a couple of housekeeping. Please visit iocdf.org/peace of mind to learn more about upcoming events, webinars, and of course to submit questions or content that you want to cover or you want us to cover. And please remember today is intended to be educational and hopefully we'll provide some resources, but this is not to replace therapy. We encourage you to have your own individual therapist that you're working through your own questions with that are specific to your treatment. Of course, IOCDF and or our webinars are not a crisis hotline. If you're feeling unsafe or suicidal, please call 988 or go to your local emergency room. I am just so excited for today. And Chris, I know you are too, so I'll let you take the floor next. But today we are having one of my favorite OCD clinicians, advocates, authors, John Hirschfeld, with us. So John Hirschfeld is the director of the Center for OCD and Anxiety at Sheppard Pratt. He is an incredible clinician. He has done so much work in the OCD field. I'm not going to read your full bio because I'll just talk instead. I think you've authored, is it 6 books now?
Something like that, yeah.
Something like that are incredible. We talk about, and last week when we were just saying you were going to be here, there were so many people that were so excited to have you here today. And so as always, you guys, please tell us who you are, where you're joining from, and any questions you have specific for John or us, put them in that pane on the right-hand side that you see so that we can be sure to answer them live. But John, thank you for all that you do in the OCD field. And I'm just so excited to have a conversation and for us to talk more about the work that we all love.
Thank you so much for having me. This a rectangle from IOCDF on a computer screen is my safe space. This is among my favorite places to be. So thanks for inviting me.
Awesome. Well, we love it. Chris, you want to hop in?
Yeah, no, John, we're super excited to have you. I mean, I feel like this is a great place to land. We talked a lot about just like the basics. And I think for a lot of people first coming out and seeking treatment, we covered that. But one thing that I want people to learn from today is that, you hear kind of like the basics, but for clinicians, for consumers, like it's not a one size fits all. And when people come into treatment, we're really, making sure that they're walking in there. It's a collaborative experience and it's a positive experience as they get better. And even though sometimes it's rough and sometimes it's tough, it's always worth it. And I think what really inspired kind of this stream for me, at least, is I run a family group and I get a lot of parents that come on there and they say, well, my loved one thinks that it's going to be horrible and they're going to have to do all this bad stuff. And it always sounds like fear factor when the parents explain it. But I'm always like, if I could record my sessions, which I can't because of HIPAA, and people saw it, I'm not like taking feces and chucking it at them, or I'm not like, we're not running around Target trying to stab people with knives, but I think people get that idea of it. So that's why I was excited to have you for, I think that's a good title. It's like 102, like what does it really look like? Let's demystify what goes on in the therapist office. That's what I'm excited for. And we felt you were the perfect person, so we're excited to have you for that.
Thank you. No one's ever called me the perfect person. We can just stop there.
I think mission accomplished. Yeah, we just end it now, right? No, just kidding. So John, why don't we start? I would love for you to start with just telling us a little bit about like your own perspective of in the field and like your both experience and understanding and education of just how you've seen ERP shift, or like maybe how your understanding of ERP has changed over the years?
Yeah, the fundamentals haven't changed in the sense that when somebody asks me what I do for a living, I tell them, well, people tell me what they're afraid of, and then I collaborate with them on strategies to confront and overcome that fear. That's what I do for a living, whether it's coming in the form of OCD or an anxiety disorder or a phobia or something like that. That's the fundamentals of what we do. And then the next question is, okay, well, how do I confront and overcome that fear? Well, the very first thing, and I think sometimes it gets lost in this dialogue about this protocol or that protocol, is listening. Right? We're therapists. That's our first job, right? And then we're OCD therapists, or we're this therapist or that therapist, right? So the first job is the listening. So Chris, you were talking about how there are these examples of OCD that just looks like a reality show or torture, and one of two things is happening there. Either that's bad therapy, or that's great therapy that person has collaborated with their therapist on and is doing by choice because they concluded together through dialogue that that's the best way for them to overcome their fear, right? Like, I don't know that particular patient that's like running around screaming target with a knife. I mean, that's going to be a very specific situation. Probably wouldn't work, but again, really our job is to know who we're working with and to listen. Or Liz, you mentioned social justice related things, right? If somebody's feeling like they're being pressured to have a certain characteristic or believe a certain thing or behave in a certain way, and it collides with their values and their social context, well, that's because the dialogue isn't really happening, right? The therapist isn't really listening. Who is this person in their context?
Yeah.
So
no, I love that. And actually, like Jeff Szymanski always talked about this when we talked about this prior, is one of the things that Jeff said is Jeff was like, he's like, I get so bothered. We were talking about how we get so bothered when people are like, hey, my patient has this kind of OCD, tell me what to do. And we're like, well, how can we tell you what to do for exposures? Your patient should tell you what to do, right? Like, right. They should be the one. You shouldn't be coming up with exposures because even I may give them some ideas and say, like, here's some things we've done before. What do you, right? But it should be a red flag if we feel like we're like exposures are being thrown at you versus you're collaborating to really create the ones that make sense, right?
Yeah, and one from a supervisory point of view, if you have trainees saying they have this kind of OCD, what's the exposure to do? The question the supervisor would be asking is, tell me about your patient. What kind of person is their patient, right? We'll get to the content later, but do they have a sense of humor? That would be a place to start, right? Do they subscribe to a particular religious tradition? That would be a place to start. Are they very intellectual? Are they very in their body? These are all questions that we would be asking in regular everyday counseling, regular everyday therapy. And then we add this layer of, okay, there's a specific content fear. How do we break it down? How do we identify? I think sometimes people forget also that ERP is part of CBT, right? So we tend to overlook the fact that not only are people doing compulsions, but they are in fact like doing compulsions for a reason that they think is good at the time. So what is their thought process that's leading them to be compulsive? Can we look at that and challenge that thought process? I'm not talking about just blanket, reassurance, you're not going to get sick kind of talks. I mean, like, actually, how did you come to the conclusion that, the best way for you to handle your fear of being sick is to wear gloves or to never touch a doorknob, right? Like, let's see if there's any way that you're thinking there that we can work with, and see if there are other ways of thinking about your experience that would allow you to do the things you want to do. And then there's the behavioral part, the exposure part. And so we can look at it from the perspective of, old-fashioned hierarchy. Let's see how much you can tolerate. This is about lifting weights and making the muscles stronger and getting better at dealing with uncertainty or being better at dealing with whatever the trigger is. Or there might be a completely other roundabout way that you do it, right? Let's say just identify that as OCD, push it to the side and ask yourself, am I behaving in line with my values? And let me focus on that. And if that's difficult, let's think about why I'm doing difficult things, or maybe some combination of the two, which is usually how it goes.
Yeah, there's two things you said, and they're both don't relate. So I'm going to ask both questions, but you're going to have to. The first thing you said, I saw a post the other day where somebody was saying like ERP is a purely behavioral treatment, and I'm glad you kind of spoke on the CBT, because that is one of the things that sometimes I think clients think is that they're going to come in and we're never going to chat because everything's reassurance. And they're going to walk in the first day and say, look, I'm afraid of harming my kid. And we're going to immediately jump into exposures day one. So maybe if you could expand on that. And then the second thing you're talking about is, I hear from a lot of clients with scrupulosity that they're afraid that therapists are going to make them go against their faith or their religion or values. Sure. So I know those questions have nothing to do with each other, but if I don't say them now, I'll forget. But can you also speak on that second part of like, we're not going to go in there and make people burn Bibles or something if that's not what they're willing to do, if that's not their faith, if that's not their tradition, things like that.
Yeah, well, I mean, I think some of that, those questions are related in the sense that people are coming in afraid that they're going to have to betray themselves, that they're going to have to be something that they're not, and go against their values or their religious beliefs. And that really should just never be the case, because that wouldn't be the case in any other form of therapy either. So I say ERP is behavioral. Yeah, sure, we're asking people to do things. I also think some in the OCD sphere, the cognitive part of cognitive behavioral therapy has some behavioral components to it, where we're asking people to intentionally think about certain things in intentional ways, and to intentionally turn away from certain ways of thinking that, at least from the user end, feels very much like a behavioral choice and not just like a word game. So, something like religion, that's for me, that's a pretty simple one, which is a person is coming in and saying, I really value my relationship with my faith, and my OCD is really messing with that. And so I'm looking at the OCD like a splinter that is between them and their faith. And I want to help them pull the splinter out. But, that hurts, and that's going to, that's not going to be easy. So we want to find out, how willing are you to experience that doubt and experience that uncertainty about where the line is? We're not going to try to cross it, but, can you learn to walk more comfortably around it? Right? If the line is some kind of sin, for example, I'm not going to say, well, sin, right? If you're kosher, I'm not going to say eat pork, right? But how comfortable can you be walking by a store, that might sell unkosher food, as an example, right? And that's where we're sort of exploring, how effective are these strategies that you've been using, avoiding and washing and ultimately not engaging in your faith practice or attending your church or synagogue or anything like that, right? That seems to be making the splinter, that seems to be building a life around the splinter instead of taking it out.
That's right.
Well
and
said.
I think I love the concept of, and I want to spend a little bit of time on this because I love it. And I think sometimes there's mixed messages in it with the advocate community. So I'll explain what I mean, but I love the idea of like, first of all, splinters to me are like the most painful thing ever. I know that, so I hate them so much. The last time you guys, I got a splinter in my
foot. Find them. Yeah.
I was crying and I was telling my husband it was worse than childbirth. And he's like, Liz, you're so dramatic. And I was like, I hate this so much. It's so painful. It was in the bottom of my foot. But anyway, I agree, right? It's all about like, we're helping you remove that pain so that you can live freely, right? You can be closer and more aligned with your values. And if there is any time, I always tell my patients that we are doing ERP, that it feels like I'm taking you away from your values, or it feels like that at your core, you don't get it, or this doesn't make sense to you. Like, I want us to have a therapeutic relationship and rapport that we can talk about that. And because that would be more damaging than good, and that's the other thing, Jeff, I'm talking about Jeff, look, he's like taught me so much, right? And one of the other things Jeff always talked about is like, therapeutic rapport is before any ERP, right? You can't just start doing ERP with a patient. You still have to build a rapport with them, get to know them, have comfortability, a certain comfortability level, but also trust with one another. And it needs to be a space where patients feel like they can talk about it. They can share, like, I don't feel like this makes sense. I don't feel like, throwing rocks at my church is not something I'd ever want to do. But instead being able to go in my church and when I have a blasphemous thought, not have to get stuck in prayers for 10 minutes that takes me away from listening to the sermon, like that may be more aligned with my values, right? In different ways, I'm going to be more motivated to do that.
And to relate to myself as a person who is having that thought in a way that's in line with my values. So maybe I'm going to have that thought. And for me to remove my attention from what's going on in church and spend that time, maybe I don't leave the church, but I spend that time doing 10 minutes of treating myself really badly. Being really unkind to myself. Well, is that in line with my values? Probably not, right? So even if I am going to have these triggers, because they might be inevitable, a lot of what we do is we teach people how to relate to what happens in consciousness, right? Well, what's arising? What are your thoughts, feelings, and sensations? And how is your relationship with them? Is it a healthy relationship, or is it punitive and critical? And one of the things I love about working with people who are different from me is that it's a challenge, right? Because I might be encouraging this person to behave in a way that's in line with their values, and I might not share their values, right? And so in a kind of almost sinister way, it's like kind of exciting for me to like help people be the best version of themselves they can be, and then in my head think like I'm not that way, you know. And it's just very, because I think a lot of times, because you brought up the advocacy community, I think sometimes people fall into this trap of thinking that they know what is the right way to be in the world, and then trying to get other people to be that way when they come in with their problems.
Yeah.
And it's not that we can't educate people or open people up to different ways of thinking, but I do think if you're going to be truly culturally sensitive, you have to be able to work with people who are different from you 100%. And have different beliefs than you. And your job is not to help them believe what you believe, but to help them believe what actually works for them and makes sense. I'm never going to give somebody an exposure. In fact, I often insist that they explain to me why they think it will work.
That's right. That's right. So I am so big on the why, right? Like I want my patients. So I always talk about this, having a baby, 2 new babies, and well, one's 20 months now, but the other one's 9 and 9 months. And when you first take a baby home from the hospital, they tell you like back is best, right? You need to put the baby on their back is best. And I always tell people that if you don't know why, you just kind of think that's an annoying slogan and like, whatever, why are they telling me how to raise my kid, right? But if you understand that like it's to decrease the risk of SIDS and like this is why they're encouraging that, you're like, oh yeah, back is best. Like that makes complete sense. Like I'm gonna, do that. And so I tell my patients all the time, I don't want you doing something because I'm telling you to do it or because you think it's what I would want you to do. I want you to be doing something because you understand the why more than I do. And you can explain it more than I can, because you guys, those are the tools we want to teach you long term. We don't want to teach you how to fight your current trigger. Our goal is that we're teaching you how to change your entire relationship with anxiety and OCD.
Right. So
and if you don't know the why and it just feels like, oh, I'm just targeting this contaminated coffee cup, it's hard to relate that to a new trigger or thought that may come up compared to if you really understand, man, this is how I'm feeding my brain or feeding my anxiety or, sending mixed signals, like, and this is actually why this is making my OCD bigger. It's much easier for you to take that and relate that to the next thought that OCD tries to throw at you.
Absolutely. Absolutely. And I think if you feel like your therapist is making you do something, and or if you feel like you're not a good person or a good enough person because you don't want to do what your therapist is suggesting that you do, the problem there is in the communication and the therapy relationship. You don't understand why that's being brought up or how it's going to help you. And the thing is, you might be right? The therapist's idea isn't always going to be the correct idea. I come up with a lot of wacky, zany ideas. Maybe we can do this, maybe we can do that. I don't know if I'm right until the person says, wait, that one could work. I hate it, but let's think about it. Right. And then so they're kind of guiding me into the exposure hierarchy more than me saying like, oh, this is this kind of OCD. So here's a chart for how we treat this kind of OCD.
Totally. I have 2 more things I really have to get to, but Chris, I want you to go. And then I'm bookmarking my stuff. So let me get back to it at some point. Okay.
No, I was going to say, I know we all work in higher levels of care, different types of higher level of care. And John, what I wanted to ask you is, what are some of the myths that you hear or some of the fears that people hear? Because I think both of you work in higher levels of care than I do. And I know just on an IOP level, clients hear the word intensive or they hear the word partial hospital or residential, and then they think even more of their collaboration is going to be taken away. Like I'm living here now, or I'm with you every day, et cetera. How, if somebody's watching this and maybe they're seeing a therapist outpatient and they look at either of your programs or they're wanting a higher level of care, how do you see that maybe sometimes consumers get a little bit afraid of? Because I don't think we've talked about it over this series.
I would start by saying intensive isn't the same word as intense, right? Intensive means we're willing to provide more time and space for your needs than is available to you in outpatient. But it's not necessarily more intense. I mean, it often is more intense or might feel more intense. But I can't speak for other programs, but here at the retreat at Shepherd Pratt, when somebody comes in with OCD, and they often come in with other challenges as well, my first job is to assess their needs and decide from there how much OCD treatment they really need in this context, in this setting. They're here because being able to know that they're in a safe place and that they have the 24/7 staff and things like that, takes one of the variables out of the equation if there's a substance use problem or some other kind of problem, right? So we take that variable out of the equation. We know where they are and we know where they're going to be tomorrow, right? And then so I meet people, they come in like, oh, I have the worst OCD ever. And it turns out actually, they have really debilitating untreated bipolar disorder, and their OCD is like really, really bad right now because they're in the middle of an episode. But the team was able to kind of figure that stuff out. And what we understand is bombarding them with the ERP t-shirt gun is not going to resolve their manic episode. So I'm going to meet with them, sure, but maybe I'll meet with them, once every other day or something like that to just, kind of keep them contained while we're getting the meds sorted out, while they're getting educated on what's really going on. And then whatever OCD is left over, then we can say, how hard do we want to hit this? Sometimes people come in and I'm like, okay, this is a case where we're going to be doing at least 2 hours of one-to-one ERP, every weekday. And, and another case might come in and it might be the same severity, but just a different person with different needs. And maybe I'll say, you know what, rather than work with the whole team multiple times a day, I'll meet you once a week and you'll meet with my colleague over here twice a week, and I'll mostly just do education and mindfulness training because, that's what you and I seem to agree your needs are in this moment.
I really love your comment of like intensive is not the same as intense, and we're the same here, in our residential program. Obviously it's even less intense in the sense that we're not inpatient, right? We're residential, but it is about meeting patients where they are. And, right now I have a cohort of 15 and every single patient is treated differently, right? It's individualized, it's different. Some need some DBT incorporated in, some might need, purely ERP that we're hitting with like a specific model, and some need a lot of ACT added in, some might need some FAP, right? It's about, as a clinician, we should be meeting each individual patient and assessing what does their OCD need, right? And or their other diagnosis or other things going on. If I have bad OCD, but I'm also going through a divorce, like we can't just ignore the life stuff that's also happening that's making my vulnerability super increased and me be really triggered in this moment. So I love that. I want to hop into go back for a second to what we were talking about with values. So one of the things, you guys, and I've talked a little bit about this, but it really kind of bothers me is I feel like there's sometimes this message in the community that, okay, what we're actually trying to teach you in treatment is how to live, that you can live by your values. You can go do values-based things while feeling really crappy. And there's this, and that's true. I don't disagree with that, right? But I feel like the underlying message that we sometimes send to the OCD community, or at least I should speak for myself, the message I believed for many years was, because I have OCD, I'm always going to struggle and I'm always going to have to be dealing with anxiety, dealing with these thoughts. And I basically just have to push through and still go try to do important things in my life. And I was kind of living for years in this white knuckling sort of environment, right? Of like, I have to survive through and still go to school and get my PhD and get my degrees and help other people while I really struggle. And that's like the best I'm going to get. Like, I really did think that a diagnosis with OCD meant I had to struggle forever. And I just want to take a second and hear both of y'all kind of like demystify that, because I think I get the principle of these thoughts of like, oh, you can live by your values while struggling, or you can still choose to do values-based things even when you're having an intrusive thought. But for me, sometimes the undertone is that, oh, you should expect that you're always going to have these scary intrusive thoughts and they're always going to have power, and you just have to like push through and live by your values anyway.
Yeah.
What are your thoughts on that?
I mean, I think what you're talking about is sort of the therapy of putting up with it, right? Like that's basically how we're teaching people is like, you have OCD and, stop overreacting to it. And that's the best that you can do is you're just going to suffer, but maybe you won't do as many compulsions and it won't be as annoying to other people. And that's not a great way to market a therapy approach. And I do see it sometimes, even at, in residential, when people are they're discharging and I can kind of tell like, they want to leave, they want to go back to their lives, but I can tell they're just putting up with it. They're better because they weren't putting up with it before, but they haven't developed a kind of sense of mastery and ownership of this is how my mind works. And what I'm always looking for, and this is where mindfulness I think plays an important role, is the fundamental change in the relationship to thoughts themselves, right? When we talk about scary thoughts, what makes them scary? What makes a word go from being letters on a piece of paper to being something that you experience as a threat to your identity, right? And I'm not saying that we're training people how to be robots who don't respond to their thoughts at all, but there has to be some kind of shift in the relationship to this awareness of like, I'm having a thought, right? And I get to kind of choose how I'm going to relate to that thought. I'm still a product of my conditioning. There are going to be times where the thought just kind of knocks me off my feet. I have to deal with that. And so there is some quality of, you might have to learn to accept that in the way that somebody who has specific allergies or asthma or something like that, there are going to be times where they're going to feel a little bit compromised by a series of circumstances that are not under their control, and it's made their OCD go haywire. But even in those moments, to be able to say like, oh, well, look at this, I'm having an OCD episode. Okay, well, how do we want to deal with it? As opposed to, yet again, I've proven that I'm defective merchandise and I'm never going to get what I want out of this life.
One of my favorite quotes that I took from a webinar we did, Chris, I think you were on it maybe too, with Shannon Shai. I can't remember. It was Shannon was talking about, and for those of you who don't know Shannon, he's an incredible OCD advocate, used to be the president of IOCDF board. And Shannon was saying, you know, for me, the where I'm at, and for me, when I knew I had like overcome OCD, is when I got to a place that I had no fear of any thought or anything that OCD could throw at me. And I just loved that, because I was like, man, like I can resonate with that. And I can tell y'all, like the first time I had a detailed sexual intrusive thought around my daughter, right? It took me for a loop for a second, right? It kind of like caught, like you were just saying, John, it like caught me off guard. And it was like, oh, like that is grotesque. Like that's not what and I wasn't terrified of it, right? I wasn't afraid of it. I didn't start responding in this way that I used to. Instead, I was able to be like, oh, that was gross, right? And I'm going to choose to not give that power and still go on with my day and do these other and treat it very differently. And to me, that's recovery. Like when you're at a place where you have no fear of any thought OCD is going to throw at you, any trigger you might have to come across, any situation that you are exposed to, that to me is like, okay, now I know how to address it or fight it.
Yeah, I like that a lot. And I like mastery as a kind of also a shift in your instinct for coping, right? So like the primary coping thought that might come up for me is something like, oh, you again, you know, like as opposed to, oh no, what am I going to do, right? It's like, oh, I know what this is and I know what to do. I might not be happy about it. But the relationship with myself in having it is fundamentally different. My go-to position is not going to be self-criticism, self-abuse, self-abandonment.
I think for me, when I was in treatment, nobody ever told me it was a chronic disorder, which I think was a good thing, because I didn't go in it thinking that, because I think people hear that and misunderstand what that means. And so I think for me, since I was never told that, I had this idea like I was going to go in for the kill and I was going to get rid of this thing. And then obviously towards the end, my therapist still didn't tell me it was chronic, but you know, she did say, look, like it's going to ebb and flow at times and you really want to be on top of it. But I think when people ask me like, how do you know you got better? For me, my answer is always like on a daily basis, OCD never comes into the equation when I factor what I'm going to do that day. It does not lead me to anything. I don't make decisions based on OCD anymore, where before it was like whatever OCD needed, that was everything I did. If that day was dirty or a bad day, I couldn't do these things. It was almost like I was waking up asking OCD, what is this day going to look like? And so when I got better and really started to like turn around and get my identity back, for me, it was just saying, look, like I'm going to do what I want to do today. And OCD may have opinions, but I don't really care. There was a really good, Fred Penzel did a really good talk at the virtual conference, and he just talked about some of like mindfulness and different, more so about getting into the mindset of ERP. And I really liked his talk. And what he talked about is sometimes we misread difficulty as bad versus it's going to sometimes have some growing pains. And if you can look at like, hey, as I'm going through this treatment and I'm having some discomfort, it doesn't mean that this is a bad situation. It actually means that I'm expanding my comfort zone. I'm expanding myself and getting myself back. And so I think I get very defensive when people say negative things about ERP, because to me, I didn't look at it, maybe in the beginning, going through it, but I didn't look at it as like torture once again, like I was saying, like reality show. Instead, I looked at it as like the tools that I needed to get myself back. And coming on the other side, I was like, man, I'm back to Chris. Like, I have my identity back. So that's the messaging I want people to hear, is like the treatment isn't designed to be difficult and put you through like these tests that you can't achieve. Instead, what it's really teaching you is like, this disorder is tricking you by fearing thoughts, fearing emotions, and telling you that things are the way that it is when it really isn't. And by going through the treatment, you're going to kind of get yourself back. And I love that as a client, discharges or we terminate, and seeing this is who they really are. I didn't get that in the first session, but now I can really see that they're funny or they enjoy sports or whatever it is.
Yeah, I love that. And I want us to get into what to expect in ERP and kind of what that looks like. And so we can hop there. I have a big question that I think I'll end today with, so I'll save that one, but it's kind of about all what we're talking about. But well, I'll start the question and we'll finish it later, but I'll start by just saying that I think what we're talking about, you guys, is that we're fighting for freedom, not functioning. And people hear me saying that a lot, right? And I love your statement of like, we're not fighting to put up with OCD. We're not fighting to be able to function, right? To like, okay, I can do enough that I can function while struggling. Like, no, we're fighting for freedom. And I want us to address at the end of today's webinar, like, how do people get to that place of functioning versus freedom? Because I was in a functioning state for 15 years. I had really severe OCD and I functioned, right? And I just dealt with it and put up with it, compared to totally not functioning, versus when I finally was like, oh, like I can actually do it all the way and get freedom instead of holding on to a little bit. And so I say that at the beginning, even though we'll address it at the end, because I think it's important as we start to talk about ERP and what to expect, that I'm a big believer, I'd love to hear y'all debate me in this, that there's kind of this like original like standard ERP, which felt more like fear extinction. Like, I'm going to help you get over that contaminated cup. I'm going to help you get over that contaminated doorknob, versus, and let's actually get to the why, right? Let's get to the core fears. Let's help you get freedom across the board. We talk a lot about patients saying like, OCD feels like a game of whack-a-mole, right? I address one OCD trigger, a new one comes up and it's worse than the one before. And then I would have rather just had the old one. And really, like, that's not what we're trying to do, right? We don't want it to be that you're just jumping from one thing to another. We want you to get freedom overall. And so I'd love to hear both of your perspectives of just, how does that look a little bit different? I mean, I think most of our consumers understand the typical ERP, right? You do an exposure and you don't do the ritual. But what else needs to come into the process for people to really start to get that freedom?
Well, part of it is what Chris was talking about before, which is, kind of living your life without permission from the OCD. I think people underestimate what an exposure that is, to take the risk of not asking permission from your OCD, to take the risk of actually being joyful and staying in a joyful space, even though outside of that space, there might be some terrible thing that's not going to go your way and it might be coming in 30 seconds, to actually let yourself truly show up the way that you are, and embrace that. I mean, I don't want to take the word exposure and strip it of all its scientific meaning, because that is also important. But I think, kind of down here on earth with like, people who are living with OCD, there's a lot that goes into that word exposure that goes beyond whether or not you touch, something dirty, right? It's that choice to turn away from an instinct that is ingrained in your psychology, that you're conditioned. It's a choice to even notice that there might be two ways for dealing with something, and you're going to deal with it your way instead of the way that in the moment feels like, what you're supposed to do or what you're compelled to do by the OCD. I would add just a footnote. There's like one person out there, I'm sure, who's like terrified of Liz McIngvale's coffee cup, and like they should just do that exposure. Like people do get these singular things where maybe generalization isn't as important, and maybe that's not exactly OCD, but it could be treated well with ERP. But to her point, if we're talking about mastery and freedom, we're really talking about generalization, right? So anybody can overcome the one thing they do over and over and over again. But it's the difference between sort of building a certain muscle at the gym and becoming physically fit or athletic. So I'm always looking for ways to take any exposure that we do and ask the question of like, well, what was the point of that, right? And if the point was that, well, now I can touch that doorknob, if that's their only issue, that's cool, but probably it isn't. Probably it's something more like, I want to be able to feel safe and free going through thresholds, like and opening up cupboards and, in the kitchen and doing all these other things. So how do we kind of take the concept that worked in this singular space and apply it to all these other spaces?
I love that.
Intensity.
I love that. But if anyone is scared of my coffee cup, I'm happy to.
You just start. It's like the just starts traveling to different areas.
That's right. I just bring it, send it. I can mail it to you.
Bring it to the conference and like put pictures of it in like different places in the hotel.
We'll put it on IOCDF booth. Anyone who wants it, Liz's coffee cup.
We created a new mascot, I think.
I love it. Yeah, we actually do use this a lot. I use this all the time, right, Chris? I'm like, my coffee cup, because it's right here.
I know. I always have my water bottle. Yeah.
But one of the things that you just said, John, that I loved is, so we do like check in and check out before ERP blocks here at the clinic. And when I first joined a couple of years ago, they were asking questions like, what are you going to do during this ERP block? Do you need any staff support? And then after, it would be things like, how high did your SUDS get? That's a scale, you guys, that we use for rating your anxiety, 0 to 10 here. Some people use 0 to 100. And how high did they get and what are they now? And it's now we ask none of those questions, right? Our questions are like, yes, it's what are you going to do? But it's like, are you holding on to anything? Is there anything that we can do to help you lean all the way in? And then our checkout questions now are, what did you do? But the second question is, what'd you learn? What did that teach you, right? And I want to talk for a second about that, because I really think this is combined with inhibitory learning, right? Is just like the shift in ERP that's happened of like this kind of older school, like habituation model, like I'm going to sit and hold this till my anxiety decreases. And the negative side of that is like, we're actually putting power on anxiety and saying that like anxiety needs to decrease and that's the measure of success, versus like the measure of success is that you face your fear. Who really cares if your anxiety decreases or it doesn't? And I learned that like I can do hard things and I can actually still enjoy that coffee, even though it felt contaminated. And so I'd love for y'all to talk a little bit about that, because I think that's such an important message for our consumers to hear.
Yeah, I was going to answer that. It's funny you read my mind, because I was going to answer that to your last question. I mean, I think that's one of the ways that I know that for me personally as a clinician, the treatment I do with clients has evolved. Is we when I was first trained and things many years ago, it was much more focused on like SUDS, et cetera. But actually it was an article by John Abramowitz, because I'm a nerd and I like to read a lot of journal articles and books and stuff like that. And just learning more about how important the processing and learning component of treatment was. And so one of the things, like you, Liz, like after if I have a client, let's say with OCD, and we go out, I'm right next to a huge mall, and we go out and we do exposures in the intensive for like 2.5 hours, and we come back. For the last component of the session, I'm really wanting to pull the learning, because what I'm trying to get the client to see, to answer your last question, is I think the way that somebody gets to a point where they're not holding on and white knuckling and they're really, advancing, is they start to get out of the weeds and out of the like dirt on the bottom, and they start to rise above, and they start to recognize like, oh, this is how OCD always kind of gets me. This is how I always respond to it. It's not working. Here's what I got to do different. And it doesn't matter if today I'm worried about germs and tomorrow I'm worried about God and the next day hitting someone in my car. All of it's the same. It's just like a pretty package on top. I always tell my clients, like, if somebody comes in the next day and their hair is up, you don't think they're a new person. So just because OCD looks a little different today doesn't mean it's a different disorder. But that learning is where I really see people advance, is they say, okay, I really learned today that I was able to, open these door handles at the mall. And then I say, okay, how can we expand that learning? Do you think you and I need to go to every mall in America and open the door? Or do you think if you go to every mall, you got this? And they're like, yeah, it's not going to be any different. So it's really getting people to not only like learn. The last thing that I really try to get clients to do, I was run support groups, and somebody said in a group once, they're like, you know what? I have a friend who doesn't do workouts. He lives an athletic lifestyle. He parks further away and he walks places. He makes sure that when he's out eating, he just naturally orders what he likes. He's always movement outdoors. And because of that lifestyle, he has the results. And we were talking about it with the treatment with ERP, with getting better. It can't be like, I do exposures here and there. It's like, it has to mold over time in your treatment to a lifestyle. And I know when I left treatment, I almost loved and relished pissing OCD off. So if I went to eat, I may want this kind of food, but I'm not going to get it. I'm going to get the one where I have to eat it with my hands. Or when I was driving, I'm like, I'm going to drive by that school because I may hit a child. Or, it's like I would deliberately go out of my way. And I think just like my client was talking about his friend who's an athlete, I think you become an OCD ERP athlete the more that you just make it a lifestyle.
Yeah, I love all of that. And I think you captured something really important, because I've heard people refer to the ERP lifestyle in a very negative context of like, I got really tired of living the ERP lifestyle. The ERP lifestyle wasn't for me. And not everything is for everybody, and that's perfectly fine. But what usually seems to be the takeaway from that perspective is that they were living a lifestyle of doing the fundamentals of old-fashioned ERP, maybe like agreeing with all of their unwanted thoughts, or leaning into discomfort. Like these could be good things, but they were finding that it was making them miserable. Every time the OCD would throw them a prompt, they'd have to kind of lean into that and be like, and it's, we sometimes call it around here Eoring, which is sort of like, just saying the negative and agreeing with the negative, and then becoming the negative and assuming the worst. And it makes sense how that could be extrapolated from ERP. But better ERP is what you described, which is finding joy in pissing off the OCD, getting a kick out of, cheating the OCD, denying the OCD of its satisfaction. It wants me to labor over, what to pick on the menu, but I'm going to pick that thing, I don't know what's in it, but, and really kind of loving yourself as a person who is not living under the boot of OCD. And that is the ERP lifestyle, at least that I'm encouraging. But it makes sense how people could feel differently about that if their experience with ERP was fundamentally about, if something makes you feel bad, try to feel worse about it.
Can I ask you another question, John? This, when I was thinking about us all, meeting and having this talk today, I think one of the things, and Liz was talking about it, is I think as clinicians and going on the article that you recently published or the blog post, like for me, it's like I learn from other people I look up to in this industry, and I look up to both of you. And I think one of the things that I really enjoy from you is your books and can you talk a little bit about the role of mindfulness in ERP and OCD treatment? Because I think that's what I really gained from you, is that role. And I know from me, coming from a martial arts background, and we learned a lot about like mindfulness and presence and stillness. It works so well in martial arts. And then I never got like a formal OCD training of mindfulness. It didn't come until reading your books. But I sort of recognized like how still my mind was and how powerful I felt in martial arts. And I'm like, why can't I do that in treatment too? So can you maybe touch on that? Because I think it's important in the work that you put out.
Yeah, and of course you can do that in treatment, right? That is the whole idea. I think ERP and mindfulness have are pretty much everything in common you can imagine, because what we're really trying to teach people is how to be better at being in the presence of what's arising. So if you're just sitting there and meditating, what's arising might be the sound of a ticking clock or an itch or something like that. And the goal would be the same. It would be to acknowledge that that's arising and not try to resist it, not try to make it go away, and not sit there and wish that it wasn't happening. Right. So when we do exposure therapy, it's a similar kind of thing. We put people in situations where they feel compelled to do compulsions. They're going to not do those compulsions, so the brain can be a witness to the fact that they can be in those situations and not do compulsions, and that will shift their relationship to the content of those thoughts. And all the while, they're going to be, instinctively tensing up and resisting it, right? Because the brain has been conditioned to think that they're doing something dangerous, right? So it'd be very natural to try to protect them by tensing up their muscles and making their breathing rapid and increasing their heart rate and all the things you need when you're really in danger. And then the goal is, in that moment, can you be in that experience? Can you allow that experience to be there, right? And so sometimes acceptance and change collide, right? So maybe the experience is a little too much for you and you're starting to panic or struggle with urges to self-harm or things like that. That's where we might bring in DBT skills. Can you pay mindful attention to those urges and also regulate a little bit to get yourself back in that zone that is challenging and tolerable, right? So in the same way that if you were doing a sitting meditation and you had a knee injury and some terrible pain was happening, there's an amount of time where you would just observe pain as an object of consciousness. And then there's a point at which you would change your position, because what is the point at this point where you're in debilitating pain, right? So long story short, at the end of the day, it all comes down to your ability to have these experiences and decide how you want to relate to them, how you're going to approach them, not automatically doing what your mind instinctively wants to do, which is avoid discomfort and go towards what is pleasant, but to actually stay where you are. And if you can stay where you are through a lot of things, what you start to notice is that life is actually more enjoyable, right? Because what happens is negative things, you kind of think of it like a conveyor belt of all the ideas and all the experiences you have, and they're constantly passing by. And if you catch these things, these obsessions, these triggers that you don't like, and you start to track them, and you're like, I hate them, I need to get rid of them, my life would be so much better if I didn't have these thoughts. You're over here dealing with that while every other experience that could be rising in consciousness is passing you by. If you're able to stay there and see like, oh, there's, one of those thoughts and that's unpleasant, but then you're still there. What is the next thought? I mean, it could be the flavor of your food, right? It could be anything that you might have been missing out on. So mindfulness is about opening up.
I have like 3 follow-up questions, and I know we're running out of time, so I'll make them quick. But first, I want to say a statement, John. I don't know if you remember years ago when we did Riley's Wish conference in Atlanta with Margaret Sisson. Though I think that may have been the first time we met, but that was so long ago. And you were doing a talk on mindfulness and OCD, and I want to tell you, I was just like so against it. I was like, oh, this is like, who with OCD can engage in mindfulness and meditation and be quiet and still? Like, what a joke. This is ridiculous, And I had all these thoughts, and I remember sitting through your talk and afterwards, like messaging people and being like, I get it. Mindfulness is kind of ERP. Like, it's right. Because I always thought, like, I was young, I had this notion that like mindfulness meant like you can just be at peace and like be perfectly still and quiet with no thoughts. And I was in the throes of my OCD back then, and I couldn't relate at all. And after your talk, I was like, oh, it's actually about like having a thought, choosing not to respond to it or engage in compulsions or rituals so you don't get stuck with it, and like letting it go. This is kind of what we do in the ERP process. And it was really, really eye-opening to me.
That's great to hear. And that was my experience for most of my life too, of like, oh, mindfulness, that's what other people do. That's what people without OCD do. Like, good for them, right? There's one other element of mindfulness that I think is essential and also very much in line with ERP, and it's curiosity. And I think that although people that I've met with OCD tend to think that they're bad at meditating and they're bad at mindfulness, my experience has been that actually once they understand the concepts and some of the skills, they're better at it than the average person, because they are more inherently curious about their experience. They are more inherently curious about consciousness. They're dealing with, or at least their experience is that they're dealing with more thoughts and emotions than the average person. And so if you could train that curiosity to actually work for you instead of working for the avoidance and the OCD, a lot of interesting things open up. We have these scary thoughts, and they make us very, very unhappy. Except when your relationship to them changes, some of these thoughts are pretty, hilarious or absurd, or the content for a scary movie, or just incredibly unlikely. And wow, that's amazing that my mind came up with that, of all things, right?
Yeah.
Find that space where you can actually be curious, and it applies to feelings, emotions, and sensations as well. So when we're doing ERP and someone's in that sweet spot of the SUDS, that 6, 7, 8 range, what's that like? What's happening in your bones? What's that feel like? Instead of how do I get away from this? Can you be curious about that? Or like dealing with uncertainty. What's it feel like? I had this discussion actually. I work with a lot of people who are more psychodynamically trained, and when they are confronted with someone with OCD, they sometimes aren't sure exactly how to behave, because they know they're not supposed to reassure or something like that they read somewhere, but they want to explore because that's the nature of their training. And I was explaining to them, I was like, you can explore what's it like for that person to not have the answer to that question. What's it like for that person to be with that doubt and make a decision that's in line with their values instead of doing compulsions? But they have to be curious about what it's like too. It can't just be your curiosity.
So I love all this, and we could talk for 3 hours, and I know we only have 8 minutes or 7 now, but I have a question, because I know DBT is something that you do incorporate a lot, and I'm curious actually clinically. I find that we have some patients who have really severe OCD, right? And they understand, they do treatment, they make amazing progress, and they really understand what they need to do, why they should do it. They get it, they're bought in, but they really struggle to do it, often because of the distress tolerance issues, right? Their difficulty, like that distress stops them from being able to lean in. They could preach it, they could talk it. So it's almost like you come to this crossroads in ERP of like, we've almost done too much ERP right now, right? Like we know how to do ERP, we know what that looks like. And I'm curious because I find that often our go-to is like, okay, well, DBT should probably be the next step. And I'm curious, like, is that right? And like, should that be the next step? Or like, when do you say, here's when DBT, because I've been struggling with it lately of like, okay, but if a patient isn't, let's say like self-harming or, they have really healthy relationships, they're not like certain things, I'm like, maybe DBT might not be as useful for them. Maybe it would, but it's really like a motivation issue more than anything. Like they're not motivated or they're struggling to find motivation to do the ERP that they know they need to do. Is DBT the right referral in that case or not? Because I know I struggled a lot with this. I never did DBT, so I don't know.
My experience with it so far, as I've become more and more immersed in incorporating it in a residential setting, is that they're really not separate concepts. I mean, they both fall under the ERP and DBT both fall under the CBT umbrella, and they're both aimed at helping you make wise and healthy choices in situations where you're distressed. And I had a patient tell me once, they didn't like DBT. It made them irritated because it was skills that they already knew how to do. It was like basic things, like how to breathe or like how to talk to somebody or whatever. And I pointed out to them, I said, it's true that you know how to do those things, and it might feel a little infantilizing to give you an acronym for something you already know how to do. But you don't do those things when you're upset. When you're upset, you get commandeered by your OCD and the other conditions that you might be struggling with here. And you forget how to do those things. When you come back, you're like, oh, I know how to do that, sure. But when you're in that state of high distress, you're not yourself. The purpose of bringing in DBT is for you to be able to remain tethered to yourself, even in moments of high distress. So like I was talking about before, when you're doing ERP, I don't want you to be at a 10. I want you to be at an 8. That's that. But if you start to get up to this place where you're not here, well, then you're not a witness to the event. Then you're not going to learn something. And by not here, that can mean a lot of things, right? It can mean thinking about hurting yourself. It could mean fully dissociated. It could mean having a panic attack. But you got to be present for it to work. So we bring a lot of, DBT incorporates a lot of mindfulness. Obviously the challenge is in bringing in the parts of DBT at the right time so as not to be used as
reducing your anxiety
as anxiety avoidance, right? It could be reducing the anxiety if the anxiety has kind of gone over into another space, but it can't be to get away from something, right? The goal should be to bring you back in to the work. And sometimes that means stopping the work. And, again, every person is different. And so it comes back to what we were talking about before, is you really need to know this person. Sometimes it's all ERP, then it's all DBT. Sometimes it's all DBT with a little ERP. Often, at least in the residential setting, I find that it's a healthy mix of both, because they have to learn how to get into distress and cope with it. And they have to also learn how to get out of distress when it's completely overwhelming and they're not going to be able to learn from the experience.
Totally.
One thing that I'm like, if we don't touch on this before you go, the biggest other thing that I hear people really fear is they hear the word acceptance, and they think that acceptance means agree, like, and want. And so when they have some of those more taboo types, the harm, the pedophilia, et cetera, when they find out that the treatment is going to learn that I have to accept that, I think that people run for the hills and want to find alternative treatments that may not be helpful because they're scared of that. And I think that I get frustrated because I'm like, that's not what we're asking you to do. So maybe each of you can touch on how do you explain acceptance in the idea of treatment for OCD?
I'll let you go, John.
I'll keep it short because we're going to run it. We could do a whole other hour just on this question, right? In the simplest, shortest way that I can describe it, it's noticing where there is resistance to the reality that this thought object presented in your consciousness, and let go of that resistance. I'm not talking about walking around in this weird world where there's a 50-50 shot that you're going to murder your child and you have to just deal with it and lean into it. That's not what accepting uncertainty means. It means letting go of resistance to the fact that thought occurred and that you were a witness to that thought. And now you're going to make a decision about how you're going to respond to it, not allowing yourself to be around your child or staying up till 4 a.m. researching how to know is not a response that's working out for you, right? So then we get back to ERP and what are different responses to do. But I find that when I talk about acceptance, people say, well, how do I do that? And acceptance doesn't sound like a doing thing. And when I frame it as, can you notice where you're resisting and let go of that? That feels more like an action item.
I love that. Let go of resistance versus acceptance. And I always tell people when we used to say like embrace discomfort, my patients are like, there's no embracing happening here, Liz. It's like facing discomfort. I'm like, fine, use your own adjectives. I get it, right? Like because it doesn't feel like fun and fuzzy and warm when we're having to do this hard work. But one of the things we talk a lot about, and I'll end the question that you posed, Chris, on this is that we are not asking you to accept your worst fears as truth. What we're asking you to do is work that's going to allow you to be disentangled from your worst fears, for them to not have power, to not have control, to not have a hold on you at all anymore, for them to just be thoughts instead of fears. And I tell people we can't get rid of thoughts, but what treatment can do is it can prevent thoughts from becoming triggers. And when you get to that place, you're at a place of recovery, and you're at a place like Chris described, where OCD gets to make 0 decisions for you in your life. And that's our goal for everyone. John, thank you so much for coming. This has been incredible. I've loved it. I hope we can have OCD 103, 104, 105, and all of these to keep going, because I think there's so much more to be added. But we really appreciate your time, and I know the community is grateful for you.
It's an honor to be here. I really appreciate being invited.
Yeah, no, thank you so much, John. You are our hope. So we're so glad that you could be part of this. And if you haven't yet, I run a family and loved ones group every second Saturday of the month. And one of the books that we always put in our wrap up email to tell people to get is your book for families. So if you're watching this as a family member, a caregiver, a loved one, John Hirschfield has 6 books, as Liz said, and one of them is specifically for family members and how to support somebody that you love with OCD. So please check it out. It's a really good resource. And thank you for being here, John.
Bye, guys.
Thanks, y'all.
John, if you have a second, stick around.
I heard that.
I think we should just have conversations in the background. People can just hear us as long as it's not anything crazy like that one time.
We are still live. It says we're still live.
No, we are. I know.